Good afternoon. We're going to go ahead and get started. We are short a panelist right now, but hopefully he'll show up and we'll embarrass him for not being here on time. I'm Holly Wilper, and I'm the president of the League of Women Voters of Champaign County. And I'd like to welcome you to our November general meeting, where we will be talking about the opiate crisis in relationship to Champaign County. And I'll tell you a little bit more about our panelists in just a minute. But before I do that, I wanted to remind everyone that next month we will not be having a general meeting, to give everyone a chance to do all the other holiday things they have to do. And then in January, we are planning to have a meeting focusing on what we as a league can do to improve diversity and keep our members more involved and active and maintain any new members we get. So that's what's on the horizon. Look, if you haven't yet gotten your email address onto our listserv, there's a sheet in the back you can add your name to, and we will do that as soon as we can. But meanwhile, let us turn back to our panel. I have actual formal biographies this time, so you'll have to listen to me talk. In the center here, we have Julie Pryde, who's the administrator of the Champaign-Urbana Public Health District. She's been employed there since 1995. She began in 1988 as a volunteer and social work intern in the HIV program. Ms. Pryde has a master's in social work from the U of I School of Social Work and a master's in public health from the University of Illinois Springfield. She's an accomplished grant writer, speaker, and has been published in several professional journals. She also tells me she has a great deal of things to say, so we should have lots of questions for her later. Next to her is Alan E. Jones, who's the Chief Deputy of the Champaign County Sheriff's Office. He graduated from Rantoul Township High School and has a Bachelor's of Science degree from Illinois State. He attended Northwestern University Center for Public Safety School of Police Staff. In his 28 years with the Sheriff's Office, he has worked his way from a correctional officer to Chief Deputy, and also served as jail administrator. He has received the Harry J. Baker Community Service Award from the Champaign County Healthcare Consumers, and I hope he also has some strong opinions. Anyway, we're going to start with about 10 or 20 minutes from each of our panelists talking a little bit about what they do and what their role is with relationship to the opiate crisis, and then we will get to your questions. Ms. Pryde?
Okay. I have presentation here, so I will open that. Do I just open it up on here?
If you just open it up,
all right, very good.
It should come up on the monitors.
Alrighty.
There it is.
It's on there? Okay, very good. So I'm going to talk about the public health's role in the opiate crisis. A lot of people were surprised that we have anything to do with opiates, but I can tell you we've been working with injection drug users since the 80s. I started there working with HIV, like she said, as an intern in 1988. And we were working with injection drug users then. I can tell you that they've drastically changed. The demographics and everything have changed over the years, but we've been doing it for a very long time. So public health's role is essentially a harm reduction type role. We got into it specifically for disease prevention. So specifically to keep injection drug users from getting HIV or viral hepatitis, so hepatitis C or HIV. And we worked with that population it started out, it was mostly heroin use back then there was some cocaine use, and then some meth use, and then we've had people who inject for hormone-related reasons. We've had people inject, steroids, things like that. So a lot of it is either illegal or kind of under the table, so that comes with its own risks. So opiate use in general can basically cause the morbidity or the illness related to injection behaviors. So that, again, that's what we were focusing on. We have seen serious abscesses in people because when you inject and you're doing it illegally, a lot of times you're not really taking the best precaution. You're not using alcohol, you're not using sterile water, you're sharing needles, you're using dull needles, all kinds of things, because it used to be almost impossible to get people to get needles if you were an injection drug user. They were using them over and over and over and over. And these abscesses would become infected, and they would, they could get blood infections from them, they could get MRSA and VRSA, which if you haven't heard of that, that's even more serious than MRSA. That's even scarier. They could also become infected with HIV and get infected with hepatitis C. And then they can also die from any of the above-mentioned problems, so the MRSA, VRSA, the abscesses, skin infections, or from overdose. So CUPHD actually started an official syringe exchange program in 2001. And if you haven't heard of it before, it's because you didn't need to. So that was part of what we did. It was a very controversial program. We actually did it before it was legal in Illinois to do it, but don't freak out because we did it under a research exemption. So technically we were legal to do it, but syringe exchange in general was not legal. So we've been doing it since 2001, and you can see there's a variety of the syringes, and those little silver things are called cookers, and we had the sterile water we provided and alcohol pads, a lot of education, and it really gave us a good working relationship with the injection drug use community at the time. And then when we started seeing fentanyl and various things come in, or overdoses happening, or we would see in other communities that they were having that problem, we could get out to our injection drug users that we worked with and tell them, hey, spread the word, this is out there, you could die from this, be careful. We also have a mobile unit. We do mobile outreach testing with HIV and hepatitis C testing. We do a lot of stuff on that mobile unit. It's out at all times of day or night. We provide information on how to recognize an overdose. It's really simple things. If we could do one thing with opiate users right now, we would try to get them not to use alone. Just if you don't use alone, you have a much higher likelihood of surviving an overdose. So even doesn't matter who you use with, as long as they are able to basically call 911, that is helpful. So part of our outreach that we do strategizes working with people who would have shame or guilt associated with their using. So this is people that are new to recovery. This is people who just get out of treatment. This is people who just get out of the jails. They are at really high risk. So a lot of times when they get out of whatever program they're in, or they relapse, they're doing it alone because of the shame associated with that. Okay, and then starting in 2010, when it became legal, we started providing naloxone and overdose prevention training. So we've been doing this for a long time. We've had great success with it. Again, we worked mostly with our injectors. So we already had a relationship with them during the syringe exchange. And I don't want to sound like it's the same injectors either, because a lot of times, new ones come in and other ones may quit. They may actually give up or recover from opiate use. So we've been working with that since 2010. And some of you may remember that back in it was in the early 2000s, we worked really hard to get a methadone clinic established in the community, and it was a big deal. It was really hard to do. We worked with it. That one never actually came to fruition, but Dr. Peterson now has a Suboxone clinic, which is wonderful. Medically assisted treatment is really the most effective. Okay, so what is naloxone? Naloxone works by reversing the effects of an overdose. That's its only purpose. It has zero abuse potential. If I were to take this naloxone, fill up the syringe, come and stab one of you with it right now, you'd probably slap me, but after that, you would have absolutely no effects from it because it would do nothing. Its sole purpose is to bind with the opiate receptors and reverse an overdose. So again, it's as non-toxic as water, no potential for addiction. Prior to opiate and naloxone being funded, it used to be a very low-cost intervention for us to do. But now that there's a demand for it, up go the prices. Okay, and also important to note, it is legal, and anyone in Illinois, anyone can be trained to administer naloxone, and they're covered by the Good Samaritan Act. So what happens during an overdose with opiates? Pretty much the breathing slows, then it stops, and then there may be lack of oxygen to the brain, which can cause brain damage, the heart stops, seizure, stroke, and death. But in the first part of that, it's just the breathing stop. So it's real, you basically need to do rescue breathing. Their heart's still beating, but they need to get oxygen in there. And if you can get the naloxone in them, they come out of it. And I've actually If I had more time, I would be able to show you what that actually looks like when someone comes out of that, because we have a video of someone who just happened to overdose during a training film that was being shot, and they were stuck with a naloxone, and they literally are just like, come out of it. And EMS has seen it, but they come out of it, and really quickly. I mean, it starts them breathing like that. That's exactly right. So our action plan for people is very simple. Recognize what an overdose looks like, attempt to arouse them, and the way you arouse someone with this, which I find interesting, is called the sternum rub, where you take your knuckles and you just rub it really hard on their sternum, and that's supposed to irritate them or wakes them up or whatever. So if they're just passed out, that'll wake them up. Then call 911 and then administer the naloxone and start rescue breathing. And even if you can't do the rescue breathing for whatever reason, just at least administer the naloxone and stay there with them, because you may have to administer it again, and you may, with the fentanyl and cart fentanyl that's out there now, you may have to administer it again and again and again. You can see how simple this is by looking up there. You basically take the cap off the little bottle of naloxone, insert the needle into it, pull it out, and stab them in one of these places. Top of the arms, thighs. And that's the extent of it. Push the plunger in and stand back, because they're going to come out of it. If there's no reaction in 3 minutes, it says then give another dose. So these are just the numbers that we have from CUPHD. From July to October of this year alone, we have seen 124 opiate reversals reported from back to our program. There's no mandate that they report back to us, but they do. A lot of times they do. So we don't know exactly how many there are. We know how much naloxone we give out, but we only know when people report back to us that they've had a reversal, and they usually are coming in to get more and say, hey, this was used on me, or I used it on someone else. And that doesn't even count all of it that's being done via EMS, police, the fire department, all the other places that are doing them. This is just one program. That gives you an idea of what we're talking about out here. And these are people that likely would be dead with no intervention because their breathing is stopped. So what we're doing now with we got a DASA grant to expand what we've been doing for all these years. We're expanding it throughout those counties with the little stars in them. And we're also expanding to more people. We have formed a partnership called PROMPT, which stands for Partnership to Reduce Opiate Mortality and Promote Training. And you can tell someone in public health wrote that acronym because it says mortality. And that was me. I create the acronyms and then I step away. No. Okay, and then, so who are we wanting to train at public health? Our main focus is to train persons who use opiates. So we like to work directly with the injectors, the families and friends of people who use opiates, friends, mental health providers, jails, probation, parole, first responders, the abstinence-based treatment, so Prairie Center Pavilion, the halfway houses, the Narcotics Anonymous, and then the medically assisted treatment, which is like the methadone clinics, the Suboxone clinics, things like that, and then places where people overdose. So they're using opiates. Certainly you're not supposed to use opiates in the library or in a grocery store or in a homeless shelter or in a soup kitchen or in parks, but they do. You can use it anywhere you can get a private moment and do it. So we try to also work with places like that so that they can be able to possibly reverse that. Okay. So that's kind of what we do at public health.
All right, thank you. Mm-hmm. Deputy Jones.
All right, thank you. Thanks for allowing me to come. She can overwhelm me with all kinds of fast-talking information and good pieces, but the thing that's important to note is that everything that's being done in the community is built on partnerships. Mm-hmm. And CU Public Health is a huge leader and partner, even with the Sheriff's Office and other providers in the community, to make this function and work. And she showed you some of those numbers again in a very narrow set to deal with. And I don't have the numbers for you from the law enforcement side, but they're significantly lower than what the EMS folk have. But we at the Sheriff's Office now for about 6 years, I want to say, have carried the naloxone with the deputies in the field. And that was provided by a grant through Carl. Now, our initial response was we didn't want the needles, and with the deputies, and there's some issues potentially, I don't know, storage or breakage, or when I get nervous and something's going on, to have to put that needle in to do some of those different responses. So we geared our response, and Carl was able to do it to give us the nasal injection. A little more expensive, but we were able to do that, and we continue to this day. And I'm always amazed at the stories that the deputies will say, and they'll tell those stories that we were here, we pulled somebody out, they got transported, we're back 2 or 3 days later, did it again, but this time it took 2 deliveries and so on and so forth. So when Julie talks about that time period where they're away and they, what's the sensitivity, or what's the term we use when they spend 2 or 3 days out and then they go back? The tolerance level's not the same. They can't take the same amount that they did prior, so that's what caused them to overdose, because they've been off for a few days. But so you get that partnership, and as a matter of fact, I just met with some of Julie's staff yesterday about a program that potentially, this prompt program, I believe, in the jail, where those that are identified injection abusers or using that could actually take one of these kits home with them when they're released. So we're again trying to do that. Now, it's not limited to public health or Carl. We at the Sheriff's Office have been longtime partnership with Rosecrans, Champaign-Urbana now. It used to be Community Elements, Prairie Center, which is ultimately here in February merging into Rosecrans. And a very interesting partnership that we have is with the University of Illinois Veterinary Medicine Clinic. The canines, the police dogs that we put on the street, spend a lot of money to train and to work with, are at risk for exposure to opioids, especially in fentanyl and carfentanil, which are very, very high doses of, I say lethal drugs, synthetics, et cetera, that are used these days to help cut the heroin that is being used on the streets or increase its potency, if you will. And it is so, I guess, like the top of a pen, of a straight pen, small amounts that would get on your skin. If you're a non-user of any type, you don't have a tolerance for it. That could cause us, the officer, the dog on their nose, when they're in there smelling and they're exposed, to immediately go into the crisis that Julie just told you about through that steps. So VetMed has done a lot of research. I cannot remember the doctor's name, but she has done a wonderful job. And our canines have partnered with them in the testing. And it's back now to the EMS, where the local ambulance services will actually trained all of their staff to triage, to address, and transport our police canines to the emergency vet clinic to deal with these types of things. So this trickle down reaches all across that spectrum. In addition, the law enforcement officers that are dealing with this on the street, we now to the point where you probably saw it back in the day, and you watched the cop show where they'd have a white powder and they'd stick their finger in and taste it and all that. Okay, I mean, I've been there 28 years and we were told never to do that. So that was a TV specific thing. But if you did something like that with heroin or carfentanil or whatever, you die. So we don't do that. Well, now if it's a white powder, we don't even touch it. We don't even test it. We're a full gloves. Sometimes we'll use masks, personal protective equipment now. So the change that's been brought about in law enforcement because of this increase of opioid use and heroin use and the fentanyl and carfentanil abuse that's taking place in the community has changed the way we've done things in law enforcement. So we rely heavily upon agencies like CU Public Health. Hey, there's this going on out here, be careful of this, the deaths are up, and rely upon that information. So we carry it in law enforcement. Now again, at the Sheriff's Office, we wear a couple different hats. We have basically 3 different divisions. We have the law enforcement, the men and women you see in the patrol cars. We have the jail. I mean, so there's a group of 60 men and women that work in the jail, and then we have the courthouse. And all 3 of these units are exposed to these issues. And in the jail, we're dealing more with the the withdrawal, than we are with the overdose. However, we still carry the Narcan, Naloxone, in the jail in case somebody were to find a way to bring it in and to use it at the jail, and we would need to deal with that. So each of our divisions in the law enforcement or in the Sheriff's Office are continually impacted by that aspect of it. So death rates and overdose rates, those things are numbers that are tracked by public health, but it's not uncommon to have an overdose or check welfare, whatever term we might use in our dispatch world, happening frequently. And if I were to pull up a call for service log across the county these days, it's not uncommon to find one, if not two, of those type of calls that take place. And then potentially the dreaded call of the death on arrival that we call a DOA, the person who has died, and it's not expected that it was any medical condition other than potentially overdose. So that itself plays a toll on the providers in the law enforcement world as well as the EMS folks, because there's not a lot you can do to help these people in that. I have, back in 2005, the Sheriff's Office partnered with then Community Elements, now Rosecrans, and many others, and we applied for a federal grant after a long series of conversations throughout the summer to try to find ways to reduce the prevalence of both the mentally ill and the substance abuse population in the jail. And that would also include the comorbidity, those that have both, one of each. I'm learning all these terms as we go along here. Started out as a police officer, and now I don't even know. But in 2005, in 2015, we started those discussions. We began realizing that there's not a lot of services in the community for these people. That they can get into programs where if they're in trouble, they can get help, they can get the Naloxone, etc. But there's not so much available to them as far as detox and treatment beyond that initial emergency process, if you will. So we got the grant. It was a planning grant. It was called the Justice and Mental Health Collaboration Program. It has all kind of acronyms, but one of the things that it had 4 goals, and primarily it revolved around reducing the use or the admission to jail for those with substance abuse and mental health or co-occurring disorders, to reduce the length of stay for those people that are in there, and then to explore the possibilities that exist in the community and what we'll do or what this community can do. It required a government and a private provider, and that's how we ended up. It's something that's been high on the Sheriff's Office, particularly in my office, in my roles in the Sheriff's Office. As I look at what we've seen in the jail, we have probably, well, let me tell you this, in October, there were 390 screenings that were done of inmates that were arrested. And these screenings, every inmate that comes in, every person who's arrested, my mom or my Aunt Julie, whoever comes in is going to go through this screening. And the officer's going to ask them 4 questions from the mental health evaluation, called the brief jail mental health screening, and they're asking 4 questions from the Texas Christian University drug screening question, evidence-based questions that help to try to determine if this person would screen positive for mental illness, mental health issue, or a drug or substance use disorder. And then from there, they're referred to an assessment with a trained caseworker who will then meet with that person and go through and actually try to determine if it's the valid screening or not. So there were 390 screenings given in October. 97 of them indicated positive for a need for an assessment. So we did some other non-scientific studies, and we knew that in 2014, about 68% of the people that came to jail were pre-existing clients of Community Elements at the time or Rosecrans at the time. Now, we provide information to Promise Healthcare. It's available to the Public Health District and so on, so they can check and see, who comes into jail, and they can see how many of those folks are their clients. Our goal, my goal, is to make sure that these agencies that provide services can see I'm providing services to this individual. They're now in jail. If I have time, I can connect up with them and try to see what we can do to break that cycle. And that really developed out of, in 2014, I commissioned a study of our data, and I said, how many people are frequent flyers? I mean, that's a bad phrase, right? So I like familiar faces. So how many people are familiar faces? And I defined it at 5 or more times. Booked into the jail 5 or more times in 1 year. That's a lot, by the way. I mean, that's a lot. There were 47. But the highest single incidence at the time was 21 for one person.
Wow.
Okay? Now, yeah, that's a lot. And And so there's 47 people that are 5 or more times in 2014. 2015, the number dropped to 40, okay, and we're full blown into our study. In 2016, our number's to 20. Now, why is that? I don't have a way to tell you that because we don't really have a full data yet. We don't have the full. This planning process has helped us identify and get some common definitions and begin a tracking process on that. But our numbers are down because we're paying attention to it. And that's 5 or more admissions to the jail in a year. And as always, I think if you pay attention to it, it's going to get the respect that it necessarily needs to try to address an issue. So we're trying to figure out ways to bring that into play. This report is available. The final report is done. It's available on the Sheriff's Office webpage, so co.champaign.il.us, co.champaign.il.us/sheriff, and then go to the public documents section. You'll see a couple different things in there. And to stick with the partnership themes, one of the things that we did was a program or a process called system intercept mapping. Foreign concept to me at the time, but essentially it was identifying all the resources that are involved in the community, where a person who enters 4 different pieces through law enforcement, through initial detention, the jail and the courts, reentry, and community supervision. And the process involved what resources are available to a person with substance abuse disorders or mental illness issues or both as they pass through the process. And bottom line is, we don't have much in this community to refer people to. Okay, and you hear that in a lot of different ways, and I want to clarify that. Those without private insurance.
Correct.
Fair way to say that?
No, that's absolutely
That's the
correct.
absolutely right way to say that. Okay, so detox is available to those with insurance that can get into potentially Pavilion or something through those ends of the deal. Others, not so much. Capacity in this, there's not a lot of people providing the services or services being provided, and some of that's going to be related to budget issues, others that's going to be related to a lack of psychiatry that's available in a lot of different places, and access is the other piece. So as part of the programs and the partnerships that we have, right now, if you were to take, and I give you a snapshot of what happens at the jail, there's a staff member from Rosecrans who reviews the intakes every day and the screenings. There's going to be somebody from Prairie Center who will look at that list. Prairie Center does the drug treatments right at this time. There'll be somebody from the Champaign County Healthcare Consumers that will look over that list and contact people about getting them enrolled through the ACA or other open markets as necessary to get them benefits. And then there'll be other ways to try to find to facilitate or provide connections as they leave the jail. The next way of importance is what we call reentry, and the county has a funded reentry program that's potentially in jeopardy with a lot of our issues at the county right now based on the budget. So for us, from the sheriff's office and law enforcement perspective, again in the street, we have these ways that we're trying to work on prevention. In the jail, we're worried about the withdrawal, we're worried about the potential exposure and overdose, but on the outside of that, from the programmatic side, what's come out of my office has been to try to find ways to work together and partner in the community to identify those gaps, to find people that can work those, to find agencies that can fill that, and to move forward. And I have to take some liberty and say that I want to be very clear. We do not need to build a building and tell people to go occupy the building and provide the services. It's not what we need in this community. We need sustainable services that some entity, whatever that entity may be, a hospital, a community provider, a foundation that's a nonprofit, or somebody that can get the services together, that can continue the partnerships with the government agencies that will work with them, and then find ways to identify those services. So I threw a lot in there, but the key is that the epidemic in opioid is not limited here. This is not a limited thing. I was in Montgomery County, Ohio, which is Dayton. I did a tour, kind of an audit of a jail over there. They have 900 beds and 50 to 75 people actively withdrawing that day in the jail. Now that's just the jail population. So, look at it in the city, it's a bigger city, but they have a bigger problem than we do, and any problem is no good. So I feel like I kind of rambled a little bit, but I got a lot of stuff that we can tell you about, and hopefully that'll open up to some questions. But one thing is I wanted to ask, how does somebody get addicted to opiates?
Okay.
That's a question I want us to try to answer before we
Sure.
get there.
All right, well, I can tell you that, opiates are a powerful and very important drug. They have a important use. So people get prescribed them. There's a lot of data that shows that there was a lot of over-prescribing once pain became one of the, what do they call it, the fourth or fifth vital sign or whatever. But that's one way. Another way is that they're using other drugs and somebody there has heroin and they use it. They get pretty readily addicted. But some people use it for pain management, and in our community we have a huge problem with untreated adult dental problems. Now, if any of you have ever had a toothache, you know that you will do just about anything to get rid of that pain. And if you go to the ER with that, which is where uninsured adults go, you're going to end up probably with antibiotics and possibly pain meds. And you need the pain meds because you can't function without it. So that's one way. They literally get addicted to it super quick through that, and then when those drugs are no longer available, then they start getting them through other means. Friends' prescriptions, family members' prescriptions. Everybody, my daughter went in to have her wisdom teeth pulled, and there was way too much opiates prescribed. So, she took it for the couple hours after, or maybe even, let's say, a day after the surgery that day, and then they're now residing in that box out in the lobby, because people, if you have them in your home and you don't know who might be an addict and might come into your house for they're visiting, or your grandkids are there, or you have no idea who's on. You'd be very surprised to learn some of the people that are addicted to opiates. And once you go from that, then you start going to the illegal. And I just keep hitting that microphone, don't I? So talk with my hands too much. Exactly.
I do too.
So that's what it is. And I have to put in a plug for his drug reentry program getting defunded, or his, not drug reentry, community reentry program, because that is very important. It is very important to keep those type of programs around, because the more services like that we get cut, the more preventative stuff that's getting cut, the more, the supports that you put on people. As that stuff gets cut, people are just going to land in the jail, and that is a horribly ineffective and inhumane way to treat mental illness, to treat substance abuse, and to treat homelessness. But yet we tend to do that in this community. And I would like to see some of the big funders step up and, address some of the social determinants of health that are related to that.
Thank you.
You're welcome.
I have a quick question before I pass it on to the audience for their questions. You mentioned that it's hard to find rehabilitation services without insurance. How about if you're on Medicaid? How many of the programs here will take Medicaid patients?
Now, I'm not exactly sure. Some do. Certainly, there are different kinds of programs. I do know that our methadone clinic in the community, however, is a cash-only program, and there's no program around it. So basically, you have to come up with that money every day, show up there, get your methadone, and leave. And while methadone is super inexpensive, it needs some supports around it as well, and it needs to be available to people with Medicaid, because otherwise they're just scrambling constantly to come up with that money. The Suboxone programs, the medically assisted treatment programs, they do take it. I don't know so much about some of the other programs in town. I know that it's certainly easier for someone with private insurance to get treatment, but.
I think I have a greater grasp of the mental health side of it than I do on the substance use. These agencies will do everything they can to deal with somebody in an immediate and urgent issue, and obviously the EDs take a lot of time with that. But what seems to be, in my opinion, it's beyond that first 24 hours. That's the part where we're looking for whether it be a formal a detox center or whether it be a treatment. There's different levels and terms I haven't yet quite mastered to get my hand on describing these events, but a place to stay for 3 days or up to 3 weeks or something along those lines as you try to go through the process of detoxification. That's significant strain on the body to do that, and so it needs to be medically managed.
And are any of you aware what happens to a person when they're withdrawing from opiates? Well, it is basically, it feels like you have no skin, you are hurting and sweating, and you're in just extreme pain everywhere. It's like, you know, when you first are getting the flu and you just are miserable and every piece of your body hurts. But what's extra fun for the people in the jail, I'm sure, is that oftentimes they're vomiting and having diarrhea all over the place, uncontrollably. It just is a part of it. And
Significant risk for dehydration.
it's a mess. It's a mess, and it is so painful that basically you would do anything to stop that pain. So what people don't understand about opiate use disorder, people who are using that are just doing it to not get sick. They're not getting high anymore. They're just avoiding what I just described to you. And you cannot go to work when you feel like that, and certainly when you're having, you know, extreme diarrhea and vomiting associated with that, you cannot go to work or school or anything. I mean, so in order for people to work, they have to be either on the opiate or on an opiate replacement until they eventually maybe wean completely off of everything. But there are people who can live their entire lives with being on something like a Suboxone or a methadone, or even opiates for that matter. I mean, if they don't overdose from it, they theoretically can function at least that way.
Questions?
If the pain medication is overprescribed, is that the responsibility of the doctor prescribing the prescription, or is it the pharmaceutical community who wants to be able to get more
Well,
control?
I mean, it's kind of, I think that's kind of a hard one to say. I mean, people, it's the same kind of deal with antibiotics. Public health does not want antibiotics overused and misused either, because it causes antibiotic resistance and horrible things related to that. I think that a lot of the opiates that were prescribed for legitimate reasons. I mean, you know, you get out of surgery, you break something, there's a lot of reasons why you have some kind of long-term condition. But, you know, another thing, and it's kind of controversial to get into, but it's important, there are other ways to deal with pain that are certainly not addictive and not as problematic. And Alan might not agree with me, but medical cannabis, for example. There has been a lot of success with some of the blends of the oils and various things related to that. It's harder to get, and it ends up being more expensive, and it's just not very well accepted. But there are other options, but, you know, I don't know that if there's anyone to blame, but I will tell you that as far as medical monitoring of prescriptions, Champaign is doing very well. They have greatly reduced, Carl and Presence have greatly reduced the number of prescription opiates that are going out of here.
So I would add to that in regards to the prescription opiate monitoring, the prescription monitoring program they have. Right now it's voluntary. Okay. And Julie gave you a scenario where it is completely possible that if my doctor is treating me for some sort of chronic pain and I receive a certain number of monthly opioid, hydrocodone or something along those, OxyContin or something along those lines, but then I also go to the dentist. And the dentist says, well, you have this tooth pain. The dentist is now going to prescribe the same drug. As somebody who is potentially teetering in an abuse or a potential for abuse, they now have doubled the access. And the dentists or anybody, let me just step back for a second. We're not required to report their prescriptions to the prescription reporting tool. It's voluntary. So if we change that mechanism, that anybody that would prescribe that would have to check that first and or report to that, there's the potential that they could see, well, you're already receiving some, so you won't need some today. It's a challenge. That's a stretch. That's, you know, in a lot of ways trying to get somebody to actually take the time to look at that before they do something. To me, it's a simple thing. It's difficult. I can't even get Sudafed for myself at 10 o'clock at night because no
Exactly.
pharmacy's open.
Exactly.
But, okay, you understand? So
Yeah.
they're not the same, but the concept, if you will, that was done for a reason, and it had to do with the methamphetamine problem. Now we're into the opioid problem, and it's time to probably look at that.
Yeah, and it is being looked at. I mean, that is part of the overall state strategy, is to limit the number of opiates prescribed for certain types of, procedures or whatever. And I do think Champaign's doing a really good job with that. We kind of are having to deal with what we've got now and then try to get in front of that and prevent anything further down the road. So we're kind of stuck with what we have right now, and we need to keep them alive and keep them infection-free until we can hopefully get them into medically assisted treatment or an abstinence-based treatment.
I'm interested in some data, some information about rates of addiction in your counties that you're covering in like the last 5 years, and in two ways. You did a sort of overview of the types of drugs that you've seen here, but you didn't indicate whether there's a chronology. You started out with heroin, and then you had other things that you mentioned. But maybe you don't have those figures with you, but if you could point us to a website where we could see, if we write letters to the editor or something, it's good to have good information. The other thing was not just what is used, numbers, but who are the people who are addicted?
Well, if we're talking, and what I was specifically talking about, and I'm going to have to turn that over to him in a minute, but what I was specifically talking about is that was people who are injecting. What were they injecting? And you can inject heroin and then some methamphetamine, cocaine, mix them together. So that was what I was referring to there, but maybe you can tell them where to get the stats on the drug use percentages.
So I'm going to step back just a second to try to get to your question. The answer is stats don't exist in a lot of these different areas, okay? But there was a county board presentations last night from the Racial Justice Task Force as well as from the Justice Mental Health Collaboration piece that I was involved in, and there were two key themes that came out of the whole thing. Coordinating councils to kind of organize the approach so that all of our partnerships are not separately, I use my fingers, we've got all these different ones going in different directions that are all splitting apart from each other, right, as opposed to coming to a head, and then data sharing and data pieces. So from the law enforcement piece, I don't have the answer to that. What happens in the jail is that we administer these screenings. If they screen positive, we pass it off to the providers. We do not receive information back about anything beyond that. Once it's given to the providers, it goes into the protection of the Privacy Protection Acts and other, and so it's very it's frustrating to me that I can't be told, I gave you Bob and Tom and Sherry and they were all screened positive for this, what was the outcome? And they say they can't tell me. But what I can get is that I gave you 390, I gave you 97, how many of them screened fully assessed positive? So I get the aggregate but not the specific. So data sharing is a significant challenge across these disciplines, even ours. I can give her her agency, CU Public Health District, all the booking and information that they would want, but then they can't tell me this is our client, that's our client, and so on, outside of a waiver.
Well, we kind of can, but when you deal with mental health and substance abuse, you have, you always hear about HIPAA laws. So here are the HIPAA laws, and that covers your health and stuff. And then you have substance abuse and mental health, and they're way up there. And Illinois is a different state. We have different laws. It's not this difficult in other states. And if you've ever been to other states and talked with the jails, you'll find out that it's much easier to collaborate in other states than it is Illinois. So that's one issue, but they're just different laws that we have to operate under. But I would look at the DASA website, the Department of Alcohol and Substance Abuse website. They have that's where they store the statewide information by county on different types of drugs and stuff. But I can tell you that when we started doing our SWAP program most of our clients were older and they were African American. Our clients now are much younger and they are Caucasian. It has completely reversed. And we know that there are probably also populations out there, or groups that we're not reaching, and we're really trying hard. So we try to get everybody that can to help us identify injectors so that we can work with them.
Is methamphetamine still a big problem?
It's still around, and drug use is a big problem. I think it's a public, what do you term a public health problem? It's a medical problem. It's a crime problem. It's
Yeah, it reaches out, it reaches all. But we never have seen at public health, we haven't seen that many methamphetamine users, not compared to my colleagues in the more rural counties. They have really seen it. So we have always had a little bit different than a lot of our surrounding counties.
I was wondering, just this comparison between the rural areas and the cities, whether you have any generalizations on who the victims are of the drug use, what, age groups, is it infected in the schools, sort of a picture that you have, even though you can't give us real statistics because of the protection and so forth, but you have this active life with who's affected.
Well, I don't know what
Talk about that
most
in
of
some
yours
fashion.
look like, but most of our clients, like I said, are younger, college age, and a little older than that even. But he may see different people than we do, because ours would have to be willing to work with us and exchange or whatever. So I don't know, but
yeah,
it's all over the place. And in the rural counties, it's almost exclusively Caucasian and really young. And if you look at some of the obituaries, it's just, they're really young.
So it would probably surprise you. I don't know that you can go across the demographics in piece, but it's very likely that a person in this room could be prescribed some of these medications. And then ultimately trying to stop would be very difficult too. You just cannot stop, even on a normal prescription rate, taking these medications. After a certain number of days, there becomes a dependency. And so a lot of us have a personality, or some of us have a personality that requires us to continue to go more, and not just one, but they need multiple in one sitting or something along those lines. So it can be very surprising. And I do have stories, but I really can't. I don't want to name names, because I don't want to actually or try to give scenarios, because it may end up somebody down the road being embarrassed. And it's potential. The professionals and all across the board could be in that scenario.
Sometime before leaving for his trip to Asia, the president, I don't remember if it was a tweet or other form of public address, declared a health emergency related to opiate use in our country. Has this declaration had any concrete impact on how either of you or your colleagues do your work regarding opiates?
It was declared a public health emergency. It already was a public health emergency. But what's supposed to happen when there is a declaration like that is there should be funds and things moving toward that, and policies and things like that. I want to see it, it looked to me like it was steering toward the law enforcement kind of thing, like changing lengths of sentences and stuff like that. And I really hope it doesn't go that way, because we've already tried that. It didn't work. You may recall Just Say No, not very helpful. Dare, not very helpful. They were not effective. And so there should be money coming with it. There has been money coming with it, but it was before that declaration. So I haven't noticed anything since that declaration.
I don't know what it's going to bring for us. And the question was, how does it impact us as say for the sheriff's office or this area, and of course I don't speak for Champaign or Banner U of I or any of those groups. We work together, but I can tell you from the training and the experience I've had across the country, there are programs, evidence-based programs that exist for law enforcement diversion of people who are substance abusers. In fact, there's a program that is called Safe Passage, and it exists here in Illinois in the northwest part of the state, and the police agencies have a partnership or funding to have a caseworker or somebody, and again, here's the key, they have money to pay for services where my son, who's a heroin user, can walk in and to the police department with his equipment and turn it in and say, I want help, and there'll be no arrest. And those types of programs have some validity to them, and they've been studied and they would work. They would potentially, are worth exploring. There's other types. It's not just that one. But I have to take you back to our problem in our community is the capacity to refer to where to go. So again, we kind of get ourselves flipped around as the chicken or the egg, and a lot of different conversations around here, but the recurring theme and everything that I've been involved in, including our grant study, was that we need the capacity and systems in place to be able to get these types of programs stood up and sustained and not rely upon federal grant funding, which goes away.
Correct.
And ultimately, doesn't exist. So
And-
from that end of the deal, I think hopefully I answered that question, is I support exploring those things, but those programs and the benefits of our people, but we have to have a system in place to be able to catch them and carry them forward, and it doesn't exist here.
Can someone who's been using an opioid develop permanent, let's say for years, can they develop permanent mental problems because of that use?
Ooh, that's a question for the doctor. I don't think so. I mean, you have addiction is its own problem. Dependence and addiction are their own problems, but I don't know. Because I know, I have known people who have used opiates, including heroin, for decades. And as long as they don't stop, they can continue working and functioning and being fine. Same thing with, OxyContin. If you have it and you are able to continue to get it, you're not going to have the withdrawal and the sickness. But
Thinking of I believe it was the second item on one of the earlier slides that you had, it mentioned brain damage or brain injury.
oh, that was from the overdose, when you stop breathing.
Well, someone who, if they've been taking it for decades, probably they've had an overdose somewhere along the line. Should that happen?
If you stop breathing long enough for any reason, and you can get brain damage. But
But it's not a direct result of the opioid, then as far as you know, it's the
not,
heart and lung.
correct. You're asking if it is like brain damage is a side effect of the opiate itself. Okay, no. So, but if same thing, I suppose if I drank a beer and tripped and fell, I could get brain damage too, but it wouldn't necessarily, I don't know. That's really a doctor question. I'm going to have to, but I don't think that's a problem.
Well, from our world, if they're arrested and they have to come to the jail and we don't have any choice but to keep them and they have to stop immediately taking what they've been taking for so long, what you described in withdrawals has to be then dealt with in a jail, and it's not a treatment place.
No.
Well, what do? You have a doctor come in then?
No.
And
No,
No, no.
you sit there.
just sit
No.
there and suffer, in other words.
That is correct. And that's what
Well,
happens in a lot of
It's not that cold. I
No.
mean,
well,
they're provided
he's
the.
there hugging them.
It's been done, but they're provided anti-nausea, anti-diarrheal, and Gatorade and other things along those lines. There's nothing else you can do,
How long does that go on?
depending upon
It's
the.
quite a while.
Weeks, months? What?
No, I wouldn't think it's months, but it's a significant period of time that is very uncomfortable. Add to it that the majority of people that come, not the majority, a good number of people that are in this condition already have some sort of other failing system within their body, or other issues that are also going on at the same time. They all just compound on each other, and that makes this a very challenging process where we're responsible for taking care of them. We're going to do the best we can, but there's nothing to do.
Yeah.
And then when they're released, I assume they get out at some point, it's probably likely they're gonna go right back to using it again after going
And-
through all the.
And that's when they're at super high risk for overdose,
Overdose.
because they go back to using it, their tolerance is down, and they may use the same amount that they used before, and it affects them differently. So-
And that's why we're partnering to talk about this other program where we give them these naloxone when they leave, potentially.
Yep, give it, yeah.
So,
So just about overdose, again, I'm not totally clear. So the overdoses that have been going on, they're due to some different drugs. It's not all the same drug. It could be.
No, it's opiates, it's opioids as a category, so that's your OxyContin, your hydrocodone, your Vicodin, your Percocets, your heroin, your morphine, your carfentanil, your fentanyl. It's that category. They all do the same thing. The fentanyl and carfentanil are synthetic opioids, and they're way stronger. Fentanyl is way stronger than heroin, and carfentanil is way stronger than fentanyl, like thousands of times.
So just one other question. If each of you could have your druthers unrestricted budget, within reason, what would your system for dealing with this crisis look like, each of you?
My system, because I'm a social worker, would deal with a bigger system, and it would be providing the social determinants of health for people so that their housing is taken care of. It's certainly easier when people have housing, they can get jobs, and jobs are the number one thing that prevents crime, prevents a lot of this problems we're working with. So I would love to see that, but barring that, something that would deal with addressing things like affordable housing and shelters and things like that. He has a good model, and it needs to be funded. And, who needs to step up and fund it are the people that have the big money. That's not us.
so in my perspective, I want, as a law enforcement officer, and be clear, I am a political candidate as well, so it's not a stump speech, but I want those that deal with the social determinant issues to be able to do their work. But what is required of us as constitutional officers of the state of Illinois to be able to have to maintain the jail facility is to have the best facility to provide the constitutional care and separation and classification issues that we have, while in the law enforcement side, be able to partner with these folks to explore these other programs so that if we decide we want to do a diversion program where we don't make an arrest, that it exists in a social capacity in the community. So they're two different pieces. I'm talking to you from the government side. In my opinion, the government, we need to take care of what we have to take care of. And then from the social side, to be able to have these services in our community would be fabulous.
If I can just follow up on this idyllic situation, I'm hearing two things. One is, Julie, you said big bucks, deep pockets. To me, I hear private resources.
Well, I mean.
And I'm hearing from Ellen that we're talking, we as taxpayers have to get behind and support the resources that you both would like to see.
Well, I mean, I think I was talking specifically about one of his reentry programs, is
Okay.
that how important these programs are. People don't, I think, pay attention to them and know how important certain things are, but what he's talking about too is the fact that we have to have places to put people who have, that's not a jail. A jail is not appropriate for most of the stuff that we're talking about. The substance abuse should not be treated in a jail. Mental illness should not be treated in a jail. Homelessness should not be treated in a jail. That's not okay. But they're forced to do it. And then that in itself causes more problems.
So let me give you a little perspective, if I can. We are crisis intervention trained police officers, a program that our officers go through to recognize people in a mental illness crisis or substance abuse crisis and get them potential services or connect them where they need to be. One of the key focuses of that, it gets into our goals, especially coming out of the sheriff's office, is to divert the people from the jail.
To where?
That's the problem.
That's the
Okay.
issue.
Good question. So, but what I can tell you is this, that in 1,000 crisis intervention contacts by police officers since April through the end of October, only 7% of them went to jail. These are people that meet a category symptomatically of a mental health crisis and or a drug abuse crisis. So we are working on it from the law enforcement perspective to try to divert those from the jail. Here's the issue. 40-something% of those in the mid-40s are going to the emergency room under a petition of mental illness or some other medical type thing
Which is also not appropriate.
because of the lack of resources. And then the rest of those folks are either do nothing or referred to, or somebody else comes in and gets involved in that. So like I said, that's only 6 months of data. It's early. My data person was asking about data. I'm all about it as well, but it doesn't exist. I'm suggesting, and I'll be blunt, we can't, at the county right now, maintain the buildings and facilities that we have because of budget constraints and continue to defer maintenance and depreciation issues all along. Having another county-owned building that somebody else would put services in would set us down the same exact path for many different reasons. So my point is that we in law enforcement should be continuing to look for ways to partner with those groups that can provide the services, whether they be a hospital, whether they be a foundation, whether they be a community provider, or so on and so forth, and help structure or build the structure into sustainability. We're not going to say, nope, do what you want, not going to help you. We're going to say, yep, we're here to support you in any way we can. But right now, I won't hurt my arm pat myself on the back, but right now all the lead is coming out of the sheriff's office to get these things fixed. And we're taking a lot of heat for that. We're not trying to do a mental health center in the jail. We're trying to be properly and appropriately provide the care for the people that we have to care for. And the conversation about consolidating to one jail is all about that, is getting out of a dilapidated facility that doesn't give us even the best ability to care for somebody into one place where all of our staff can be resourced and referenced, and so that these agencies that come into our building actually have a office to use to try to work with in confidentiality issues and work with the inmates that are there dealing with. Because right now it's out in the middle of everywhere where you can hear the conversation and they can't. I ramble, but as you can tell, I'm passionate about it, and I hope that sometime we can get there. I don't have the magic answer.
All I know is that what has happened over many years, institutions for the mentally ill were allowed to just be hideous, and then there was deinstitutionalization, and that was the great, we all thought that was going to be wonderful, and it would be, had the funding followed to do the community-based mental health services that were promised with it. That was what was supposed to happen. Am I right, Dr. Gullerud? We were supposed to have funding was to follow the people in the community so that they would not have to be in institutions. And by default, we've just said, meh, jails, it's your problem now. ERs, you deal with them and put them out. Because ERs, again, there's only very little they can do. That is extremely expensive. And I assure you that you're all paying for that to a certain degree. It is very, very expensive, and it's very expensive and inhumane to put people in jail for various issues that they have absolutely no control over.
I think your comment, as an educator, social work educator, we look at the research, what seems to be effective, and we come up with these little models, but it takes money, it takes will, it takes political action to achieve those, which is sorely lacking, especially in the populations that require intensive care.
Yeah, because look how much, if Rosecrans was here, I'm sure that they would be happy to tell you how much their funding has been cut over the years. And that's just not them. That is cut for all mental health services. Cut and cut and cut. Same with substance abuse. If Prairie Center was here, they would tell you the same thing. So again, the idea of deinstitutionalization and the concept of it is certainly valid, but it has to have resources flowing to the places that are the experts and that do it. because that is not the jails and that is not public health. This is not our thing. We're just a Band-Aids on the bigger problem, and the bigger problem is not getting addressed.
I think what's worrisome, is that this is not just a local problem.
No,
It's
it's absolutely a national problem.
And the inability.
And the Affordable Care Act offered some hope with the paying for mental health services for everyone and paying for substance abuse. However, then because of all the defunding forever, then there was a capacity issue. And that now that's up in the air. So, if they don't have to pay for it, the insurance industry, they will not.
I'm thinking about the person you just let out of jail and who's gone through withdrawal. Does public health step in a case like that? Do you call public health and say, okay, somebody just got out, they're
No.
on their own then?
No, but let me tell you what is happening. And we have worked with the jail forever. I mean, we go over there and we do flu shots and we do STD and HIV testing and things. And if we have a client in there who's HIV positive, for example, our case managers go right over there, work with the client before they get out so that there is that handoff, immediate handoff, so that they're hooked up with services before they get out of jail, before there's a failure. We're working and we just actually, that's what he was talking about. He just met with some of my staff yesterday about doing the same type of thing, only when they get ready to get out of jail, that prompt bag that I was passing around is there, waiting for them, and they've been talked to and they know what services are and they know not to use alone, despite shame or whatever, and not, to taste, it's called tasting the drug to make sure how strong it is before you shoot it all in there. So there's a lot of harm reduction that can be done. So we are talking about that, but, it might surprise when people are let out of jail, they don't usually want to hang around and wait for
She took the words right out of my mouth.
somebody to come talk to
Two
them.
sides of that. Was one, they're ready to go, and I don't blame them.
Yeah.
And number two is that we're not inclined to keep people beyond the time of which they're required to. Matter of fact, we're not going to. It's a constitutional issue that when it's time to go, it's time to go. However, I got to tell you a name. Remember this name, Carrie Voges, Kareevoges. Carrie Voges is our captain, and she's our jail administrator right now, and she's phenomenal. And one of the main things that we care about and that she focuses a lot on is this release issue. When it's cold, we're not sending people out the door saying you have to leave. You can stay in the lobby till your ride comes. We'll give you a bus token if you need to. The bus stops out on Learman Street. She's actually even driven inmates to appointments with Rosecrans or Prairie Center so that they can actually follow up once they've been released. So we're not going to get them all. We can't. We're going to do our best, but we're just not going to catch everybody. They're going to get out the door. They're going to go. But we have a priority as much as we can address release planning and release, getting folks to that. That's part of this overarching project that we have in the jail right now. So it's certainly, you have a good concern that you've recognized that one we've been dealing with for years.
And there, I have to say, Champaign is literally a model community. If you were to see some of the counties that I deal with and talk to some of the administrators and the stuff that they're dealing with, they have no cooperation with the jails. They have no even though they may be a county entity, they have no collaboration with their other agencies. It just doesn't happen. And they're even trying to expand this program into get the Naloxone out through EMS or through the police, and they have people telling them, no, if they die, then we don't have to deal with them anymore. That attitude's out there, and they are emboldened to somehow say that, and it's really sad. But so Champaign is really an amazing model. Of course, we're going to always be complaining about everything because we always want it to be better, but we really are lucky in this county, and things can always be better, and we always strive for that. So,
can you give us some picture of what the prevention situation is now in terms of programs in the schools, their curriculum elements for the kids at the freshman level in high school, for instance, where they go through a whole string of lessons in that, but do you have people who are going into the schools and giving preventive talks? Is there literature that's
Yeah.
available to students? You know, is there an active prevention situation, because the population there is constantly changing?
Yeah. We don't have it, but I know that Prairie Center has youth educators. I know that they use evidence-based substance abuse prevention programs in the schools. So I.
Good access. I mean, is it something that's, you know, in this crowded curriculum that kids have? Are they really getting there, or is it just something that exists?
I don't know. I'm not the one that evaluates it, but I do know that at least, you know, the state agencies are having when they fund things, they are now at least making people use evidence-based programs, showing, you know, things that actually have worked, have been proven to work. So that's encouraging, but I mean.
Can we have any last thoughts you'd like to leave us with before we close our meeting?
Yeah. Trust what I've said, but go verify it. Take a look at it and examine it. You know, again, 28 years I've been in law enforcement, and I went through a complete change in my approach. It used to be arrest them, lock them up, put them away, move on to the next call. And now as an administrator, and the times have changed, I'm now trying to find ways not to cause problems, but to try to work problems out, if you will. So the things that I've talked to you about, you're welcome to challenge me. You can call me. Ms. Wysocki knows that I'm available and interested in conversations, and we'll do that. But if you can find ways to support the projects that are taking place in the community, I would encourage you to do that.
And, you know, my thought is that same type of thing, but, you know, I am very concerned right now with what is going to happen to a lot of the people we're talking about if the Affordable Care Act goes away, because we have seen people be able to access treatment, be able to access mental health services, be able to access basic health care that we haven't seen in years and years. And I am really, really concerned about that. So, you know, do what you can.
Well, I would like to thank our panelists. Shall we give them a round of applause? And just a reminder that this will be rebroadcast on UPTV, and actually usually the UPTV presentations are also available on YouTube if you would like to look them up there. Thank you so much for coming.